So today's topic is continuous renal replacement therapy with ECMO. As Dr. Sneha has already mentioned, this is not a procedure which is not commonly used. And this procedure is usually done, ECMO procedure is usually done in centers with a lot of high cardiac volume. And of course, it is also used in intensive care settings. And often these patients are really sick, and it is often done as a rescue therapy. And as you know, with the multiple organ failures, the kidneys are one of the organs which get involved earliest. So naturally, we like to support these patients with some form of renal replacement therapy. And often the renal replacement therapy that can be done in these patients is continuous renal replacement therapy. So the outline of my talk would be something like this. We'll discuss what is ECMO, causes of acute kidney injury in ECMO patients, and how to integrate the CRRT circuit into the ECMO circuit. So first we will come with a case. So this is a 34-year-old male company executive with no comorbidities, and he was admitted to the intensive care unit with acute bronchopneumonia sepsis. He was initially treated with a broad-spectrum antibiotics, but his respiratory function steadily deteriorated and had to be intubated and mechanically ventilated. So his nasal swab influenza PCR was positive, and despite early initiation of oseltamivir, he developed ARDS with no response to concoction ventilation and other lung supportive measures. He was hemodynamically stable, however, became hypoxic despite maximal ventilatory support. And subsequently, there was acute kidney injury. He becomes anuric with hyperkalemia. So what other life support measures are possible in this patient? So this is a young patient with no comorbidities, salvageable patient, and like we are faced with a clinical dilemma, how to support this patient and to what extent we should support this patient. So we'll discuss the answers to all these clinical cases at the end of my talk. Now we'll come to a second case. This is a 45-year-old female with a background history of dyslipidemia and a strong family history of coronary artery disease. She developed acute coronary syndrome and was detected to have a triple vessel disease on coronary angiogram and had to be taken for an emergency bypass because of the complexity of the vascular lesions. And post bypass, she remained on a mechanical ventilator and was dependent on a cardiopulmonary bypass. And her vasopressor support were at a maximum with a mean arterial pressure of 50, and she developed acute kidney injury, anuric, severe metabolic acidosis, and hyperkalemia. Again, what are the other life support treatments are possible in her? So again, we'll discuss all these answers at a later stage. Now, extracorporeal therapy for prolonged, ECMO is an extracorporeal therapy. It is used for prolonged but temporary support of the heart or lung function or both in patients suffering from a cardiac or a respiratory failure using a mechanical assist device. So this is a temporary support, but it can be prolonged for some time, and it is used for the support of the heart or the lung function or both in a patient suffering from a cardiac or a respiratory failure. And often we give rest to these organs so that they recover from the primary insult. So that is the main purpose of this ECMO program. And usually it is indicated when the risk of dying from the primary disease, despite optimal treatment, is as high as 80%. And it is a first-line mechanical, cardiac, and respiratory support, often used in these sickest of all these patients. So what are the terminologies for extracorporeal life support? So there are a lot of life support treatments are there, like cardiopulmonary bypass, which we all know, that is used in OTs, operation, cardiac surgical operations theaters for various cardiac surgeries. Then you can have extracorporeal lung assist, then extracorporeal carbon dioxide removal, arteriovenous, arterioventricular carbon dioxide removal. Then you must have heard about ventricular assist devices used for cardiac support. Then left ventricular assist device used for left ventricular support. Right ventricular assist devices are there. Then biventricular assist devices are there. Then there is something known as ECPR. ECPR is a term used when you use ECMO support to support the patients, like a VA ECMO. Like if there is a young patient, like a 24-year-old or a 20-year-old patient with no obvious cause, goes into cardiac arrest and resistant to CPR, then you can put these patients on ECMO till the cause is being worked up. So this is known as eCPR. Then of course we come to the extracorporeal membrane oxygen. It is used for both cardiac and respiratory support or for respiratory support. Now a brief thing on cardiopulmonary bypass. So cardiopulmonary bypass, the duration, it is most commonly. So what is the difference between a cardiopulmonary bypass and an ECMO? So cardiopulmonary bypass is also a technique which is used through extracorporeal support, which is used in the cardiac theater to support the patient undergoing open heart surgery. Again, these are the key differences between cardiopulmonary bypass and ECMO. The duration in cardiopulmonary bypass is only hours, where we can continue ECMO for weeks. Configuration is always VA, that is venous to arterial. Here it is venous to arterial or venous to venous. Oxygenator is polypropylene. Here it is, whereas in ECMO it is polymethylpentene. Anticoagulation dose is high in cardiopulmonary bypass. Often there is an associated reservoir, and the usual location where you do this cardiopulmonary bypass is the operation theater, whereas this ECMO is done in the intensive care unit. And there is a risk of hypothermia usually during surgery, and often you require an aortic cross clamp in cardiopulmonary bypass. So in cardiopulmonary bypass, you take the blood, get it into the reservoir, then it goes through the various pumps, then it goes into the oxygenator and the heat exchanger. The purified oxygenated blood is returned to the patient's body, to the aorta. This is what happens in a cardiopulmonary bypass. So this is a crowded diagram, telling about the ECMO fundamentals. So these are the fundamentals of ECMO. So in ECMO, what we do is there can be a veno-venous ECMO or a veno-arterial ECMO. So in a veno-venous ECMO, you put in a catheter into the right femoral vein, and the blood is drawn somewhere at the level of the inferior vena cava. So the blood, the deoxygenated blood from the inferior vena cava comes to the pump. Usually this is a centrifugal pump. Sometimes you can have a roller pump. So currently all the pumps, all the ECMO machines use a centrifugal pump. And from the centrifugal pump, the blood moves into the oxygenator. And the oxygenator is a part of the lung where the blood is oxygenated and the carbon dioxide is removed. So oxygen is added into the blood, carbon dioxide is removed, and often the oxygenator is integrated with a heat exchanger. So the blood is heated up, then it goes, again there are sensors which will, so this sensor is important. So this sensor detects whether there is an air bubble within the returning blood, and depending upon where you return the blood, it can be a veno-arterial or it can be a veno-venous. So when the blood is returned via an inferior vena cava into the right atrium, it becomes a veno-venous ECMO. So actually, the VA ECMO, it produces a circulatory support. It adds an artificial lung in series with the native lung. This is so you have to remember that this circuit is in series with the native lung and the heart, and the oxygenated blood is returned back into the patient's body. So you are actually supporting the lung function. Whereas in veno-arterial ECMO, instead of returning to the right atrium, it is the returning blood is returned into the femoral artery, and it enters the femoral artery, and the tip usually goes into the somewhere near the aorta. So this is a veno-arterial ECMO. So if we are using a veno-arterial ECMO, you are supporting both the function of the heart as well as that of the lung. And this is a circuit which is in parallel with the native lung. So these are the important things that you should remember. And the oxygenator is supplied by what is known as the air and the room air as well as oxygen, depending upon the pressure gradients, partial pressure of oxygen are mixed in a blender, and this is known as a sweep gas. And the sweep gas enters into the oxygenator for gas exchange. So this is in general about the ECMO. So you should know what is a venous ECMO and a veno-arterial ECMO. So in veno-venous ECMO, so this is a diagram showing the veno-venous ECMO. The blood is drawn from the femoral vein. It goes through the centrifugal pump. Then it goes through the membrane oxygenator. And from the membrane oxygenator, the blood gets oxygenated. Oxygenation and decarboxylation happens. it is returned via the jugular vein. So the oxygenated blood is returned into the right atrium and the blood is withdrawn from the inferior vena cava. Now in veno-arterial ECMO, you take blood from the femoral vein, from the region of the IVC. It goes into the centrifugal pump, it goes into the oxygenator, and instead of returning back into the right atrium, the blood is returned into the femoral artery. So there is a cannula which pokes into the femoral artery and it goes into the aorta and mixes up with the oxygenated blood, which gets oxygenated by the patient's lung also, and depending upon the cardiac function. And the problem with the cannulating the femoral artery is that because the blood flow is so high, you can have a distal limb ischemia. So instead of putting one cannula up along the aorta, along the femoral artery into the aorta, you have to put another artery down into the distal femoral artery to maintain the perfusion of the limb. So actually there are two returning cannulas, one into the femoral artery directed upwards and the one directed distally towards the left leg to prevent the limb ischemia. So this is a veno-arterial ECMO, and you have to remember that it supports both the heart and the lungs. So if you want to support both the heart and the lungs, you go for a veno-arterial ECMO, and if you want to support only the lungs, you go for a veno-venous ECMO. So these are the differences between a veno-arterial ECMO and a veno-venous ECMO. So veno-arterial ECMO, you can have a cardiac as well as respiratory failure. That is the indication for doing the veno-arterial ECMO, and veno-venous ECMO you do it only in respiratory failure. And vascular access is from vein to artery. Here it is from vein to vein, and the pump flow is somewhere between 80 to 100 ml per kg per minute. So usually these pumps can sustain a flow of 5 liters to 10 liters per minute. So this is a very active pump. So oxygen delivery is mainly by the cardiac output and the pump, and in veno-venous the oxygen delivery is by the native cardiac output only. And one important thing you have to remember in patients undergoing veno-arterial ECMO is that the arterial waveform will be flattened because it is delivered by a centrifugal pump. This will be a non-pulsatile flow. So when you feel the pulse, you won't really feel anything because the flow is non-pulsatile. And the cardiovascular effects will be the afterload as well as the preload will be reduced in a veno-arterial ECMO. The main complications are systemic emboli, possibility of infarction and gangrene are there. Whereas in veno-venous ECMO, there is a risk of pulmonary embolism. Now coming to veno-venous ECMO, what are the main indications for doing it for a veno-venous ECMO? So the main indications for a veno-venous ECMO are it is usually done for a primary lung condition. Usually the most common indication would be in ARDS, where the risk of mortality is 50% or more. Or if you do some scoring systems and find out whether you have to look for a 50% mortality risk or a 80% mortality risk, depending upon the PaO2 or FiO2 ratios, then and on gases and on the ratios depending upon what fractional level of inspired oxygen is, and all this there are a lot of scores which will tell you what the mortality risk of the patient is. So if there is a 50% mortality risk or if an 80% mortality risk, depending upon the scores, you consider the patient for undergoing a VEB ECMO. Then other conditions are a hypercarbia on mechanical ventilation, and again with a high plateau pressure. So a high plateau pressure says that the lungs are generally very stiff and resistant to mechanical ventilation. Then a severe bronchopleural fistula, and those patients on a lung transplant list, they are awaiting a lung transplant, and if they have to be sustained, then you will have to do a veno-venous ECMO. Then complex tracheal surgeries. Then very rarely it is done in status asthmaticus, unresponsive to all lines of treatment. All these are indications for doing a veno-venous ECMO. Now coming to veno-arterial ECMO, this is for a lung supporting the heart as well as the lung. So primarily it is used in support of the heart, where you get a severe refractory cardiogenic shock. So like it can be done in patients with acute coronary syndrome, cardiac dysarrhythmia, and cardiac stone refractory to other measures, sepsis with profound cardiac depression, drug toxicity like severe beta blocker toxicity or some severe drug toxicity with a cardiogenic shock, myocarditis, then pulmonary embolism with a cardiovascular collapse, isolated cardiac trauma, then acute anaphylaxis, then post-cardiotomy as the patient in our case discussion had, and inability to wean from the cardiopulmonary bypass after cardiac surgery, then post-heart transplant, then chronic cardiomyopathy when the patient is considered for a transplant, then bridge to transplant, then it can also be done in amniotic fluid embolism, severe hypothermia, then primary graft failure after cardiac transplant. All these are indications for doing a veno arterial ECMO. Now, the general contraindication, before you subject these patients to all these rescue therapies, always you should have an exit strategy and you should rule out all the contraindications. So this, in general, the contraindication are, it depends on from center to center and the proficiency of the unit as well as other conditions associated. But in our setup, it would be the main financial issues. Now, the various contraindications are advanced stage, disseminated malignancy, severe degenerative brain disease, unwitnessed cardiac arrest, post-CPR time more than 45 to 60 minutes, especially for putting in a patient for eCPR, then aortic dissection, severe peripheral vasculopathy, then severe aortic regurgitation. So anything concerned with the aortic valve with regurgitation is a contraindication because it will distend the left ventricle and it is not good for the patient. Then non-eligibility to heart transplant or ventricular assist device, especially those patients with severe heart failure. Now, what are the various complications associated with ECMO use? So the complications can be divided into 6 headings. One is the vascular complications. Vascular complications include vessel dissection, vessel perforation, pseudoaneurysm, limb ischemia. Then ECMO-related, circuit-related issues like the pump, there can be thrombosis within the pump. Due to the activity of the centrifugal pump, the blood can undergo hemolysis. Then there is an interesting condition known as a north-south syndrome or a Harlequin syndrome, where the top part of the patient's, the head of the patient as well as upper limb becomes blue in color and the lower limb becomes is well oxygenated. This is due to improper mixing of blood and mixing of the deoxygenated as well as oxygenated blood. Then other complications include bleeding due to the use of anticoagulants like exercise bleeding, retroperitoneal hematoma, intra-abdominal bleeding, stroke, GI bleed. All these bleeding complications can happen. Then it can lead to thrombotic complications like intracardiac thrombus, thromboembolic stroke, vascular thrombosis. Then this is a real problem when you do ECMO, where you get a pump or an oxygenator thrombosis. Then you can have infectious complications like bacteremia or cellulitis. Of course, you can have a ventilator-associated pneumonia, end-organ hypoperfusion like ischemic hepatitis, acute kidney injury, seizures, and hypoxic brain injury. Then now coming to the second part of my talk. So these patients usually develop acute kidney injury, even though their renal functions were normal at the onset of when you put the patients on ECMO. So the causes of acute kidney injury in patients on ECMO can be broadly classified into 2 categories. One is the patient-related causes, the other is ECMO-related causes. So the patient-related causes, of course, these are really sick patients. So the patients will be having hypoperfusion, ischemia, reperfusion injury, loss of autoregulation, which leads to acute kidney injury, hypoxia, vasopressor use, nephrotoxic drugs, and renal failure can be part of the sepsis-associated systemic inflammation. Then there can be organ crosstalk with a cardiorenal syndrome. All these things can happen. Then ECMO-related factors, as I already told you, when the patient is on a VA ECMO, there will be loss of pulsatile flow. And pulsatile flow is actually needed for the best perfusion of the organs. So whenever there is a loss of pulsatile flow, it can lead to acute kidney injury. Then ECMO-related inflammatory cascade, then fluid overload, then perturbations within the hormonal systems like renin-angiotensin and aldosterone dysregulation. All these things can lead to acute kidney injury. So ECMO can lead to direct effects like a non-pulsatile flow. Non-pulsatile flow will lead to decreased renal blood flow, decreased cortical and medullary flow, decreased renal oxygen delivery. Then ECMO itself can lead to hormonal dysregulation and acute inflammation. Systemic inflammation can happen. All these can lead to acute kidney injury. And the renal ischemia again can lead to renal tubular necrosis and acute kidney injury. These are in general the causes of acute kidney injury which are related to ECMO. Now, what are the common indications for dialyzing a patient on ECMO? So the most common indications are one is fluid overload. So when you do when you keep the patients on ECMO, often they become fluid overloaded, and you need some form of renal replacement therapy, especially when they develop acute kidney injury also. Then other indication would be acute kidney injury and electrolyte disturbances. Then there are less other indications like it can be used in the treatment of sepsis, liver dysfunction, poisoning, then optimizing nutrition and improved protein delivery and cytokine removal. Of course, very controversial topics. Then what are the pros and cons of different renal replacement therapy modalities using ECMO? So you can have various renal replacement therapy like intermittent hemodialysis, sustained low efficiency dialysis, continuous renal replacement therapy, as well as peritoneal dialysis. Now, the problem with this intermittent dialysis, and like they said, they can be easily integrated into the ECMO circuit, and the low cost is there. But the main disadvantage is hemodynamic instability. So, as you know, the solute removal and the fluid removal is again very fast with intermittent hemodialysis, and it can lead to hemodynamic instability. Again, because of the rapid solute removal, they can run the risk of cerebral edema and dialysis disequilibrium. These are the main problems with the intermittent hemodialysis and even with sustained low efficiency dialysis. Then CRRT is the most common modality that is used, and it can be easily integrated into the ECMO circuit. Better hemodynamic stability is there, more optimized fluid control because everything is under your control. So continuous solute removal, very good, and it resembles a physiological state of the patient. Then allows other blood purification therapies for systemic inflammation. Again, the main limiting factor is high cost. Then PD is also another modality which is being tried on patients with ECMO, and it has low cost. Technically, it is simple, no anticoagulation, and good for the hemodynamics. And it is primarily used in the pediatric population, much less of experience in adults. Again, there is a risk of peritonitis, and it may lead to failure to wean from ECMO due to interference with the diaphragmatic movements. So these are the various renal replacement therapies which can be combined with ECMO. Now, the topic of interest or dialysis segregations will be how to combine continuous renal replacement therapy with ECMO, how to integrate the circuit. So there are three modalities by which you can do CRRT in a patient who is already on ECMO. So one is an independent CRRT vascular access. Second is an inline hemofilter into the ECMO circuit. Then the third modality is the introduction of the CRRT machine itself into the ECMO circuit. You have to note the difference between these two. Here you are introducing only the hemofilter, where you are introducing the CRRT machine itself. Now, independent CRRT access. Even though we say that we can integrate the CRRT circuit into the ECMO circuit, if you take how people use CRRT along with ECMO, this is usually the people use it as a separate independent CRRT access. The main advantage is the two circuits are independent, and you are not dependent upon the perfusionist. Of course, when you are running an ECMO, there will be a cardiac perfusionist along with the ECMO, and you will have to really integrate with the perfusionist to stop the CRRT program as well as to run the program well. So here there is independence of CRRT, so you can decide on what treatment modalities that you can use. However, the main disadvantages is a limited site for CRRT vascular access. Now when you are combining two circuits, there is a very high risk of bleeding, and these are the access is the main issue that you can face when you are running an independent CRRT circuit. Then the other modality is just like introduction of a hemofilter into the ECMO circuit. You are just putting a hemofilter into the ECMO circuit, and the blood flow into the hemofilter is driven by the ECMO pump. So here there is the main advantage is that it is relatively simple and inexpensive, that you are just putting a hemofilter into the already existing ECMO circuit. And here the problem is it is mainly you can do only fluid removal. The solute or the cytokine removal might be not good, and the diffuse clearance is much less because you are not running a dialysis solution or anything. So this is primarily done to remove fluid from the patient's body. Now the most commonly used procedure is introduction of a CRRT device into the ECMO circuit. Again, the main advantage is that it allows avoids additional catheter-related complications, including risk with catheter insertion, infection, and mechanical complications. But the main problem is a problem with the pressures. This is a ECMO circuit. This is the blood is taken from the patient's body. It first goes into the centrifugal pump, and from the pump it goes into the artificial lung or the membrane oxygenator. It gets oxygenated, then it returns back into the patient's body. This segment before the pump is negative. So, and this segment, the segment after the pump is positive. That you should always remember. So you will have problems when you connect the CRRT circuit. If you connect it, it's pre-pump or post-pump. So there will be pressure differences. When you connect the CRRT circuit pre-pump, often there will be low pressure alarms. And when you connect it post-pump, there will be high pressure alarms. And frequent pressure alarms can lead to stoppage of the pump, stoppage of the CRRT pump, and it can lead to interrupted clearances, and your CRRT might not be effective also. And frequent stopping and starting of the CRRT can lead to increased risk of thrombosis, and the CRRT circuit can get thrombosed. And if you connect pre-pump, again, because being it is a negative, there is an increased risk of air embolism. And if the air enters in the pre-pump segment of the ECMO circuit, the air can enter the pump, and the pump detects air, and it stops. And the whole ECMO circuit can also get thrombosed. Now this is an inline hemofilter, and sorry for the short diagrams. So this is a patient's body. The blood is taken. This is primarily the ECMO circuit. So the blood is taken from the patient's body, it goes into the centrifugal pump, then it goes into the oxygenator, returns back into the patient. This is an inline hemofilter. So after the pump, the blood is taken from the patient's ECMO circuit, goes into the hemofilter, then the fluid is removed and the blood is returned back into the patient. So this is inline hemofilter. Very technically, very easy. You don't require a CRRT machine. The blood is driven by the ECMO pump, and you can only attempt removal of fluid. This is the inline hemofilter. Now you can connect the integration of the CRRT in the ECMO circuit before the pump. So this is a pump of the ECMO machine. The inlet is here. The inlet for the CRRT machine is here. Then the blood is returned again back into the pre-pump segment. And as I already told, this part of the pump is the pressures here are negative. So there will be multiple pressure trigger alarms. There will be a risk of air embolism, air entrapment within the CRRT as well as within the ECMO pump, and it can lead to stoppage of the ECMO. And the ECMO also can be disrupted by the use of this technique. Then you can integrate the CRRT in the ECMO circuit after the pump. So when you use it after the pump, the blood is taken from the CRRT, from the ECMO circuit after the pump. It goes into the CRRT machine, gets filtered, then it is returned pre-pump. So this is another way of how do you integrate the CRRT circuit into the ECMO circuit. So CRRT circuit is actually embedded within the ECMO circuit. ECMO circuit is a primary circuit. Here the problem is again this part of the pump there will be high positive pressures. So because of the high positive pressures, it can trigger high pressure alarms within the CRRT machine. Then you can, this is one of the most common integration techniques which is used. You take the blood from the ECMO circuit after the membrane oxygenator. It goes into the CRRT machine, gets purified, and it is returned just before the oxygenator, membrane oxygenator. And there are lever locks available which facilitates easy transfer of blood from the ECMO circuit. The lever locks are available before the oxygenator and after the oxygenator. And this is one of the most commonly used techniques of how to integrate the CRRT into the ECMO circuit. But the thumb rule is that you should always access to the filter can be from anywhere on this ECMO circuit, but the return line should be always pre-oxygenated. So whatever you do, you can access a line from anywhere within the ECMO circuit, but the return line should always be pre-oxygenated, because this is a very important thing, because this membrane oxygenator also serves as a gas detector, and all the gases will be trapped within the membrane oxygenator. So you should not return your CRRT line after the membrane oxygenator. It can lead to there can be a risk of air embolism. And what should be the anticoagulation? No additional anticoagulation is required apart from the heparin on the ECMO circuit. And this is in general, usually you don't require any separate anticoagulation, because the ECMO already the ECMO circuit already will be primed with heparin, and it will be anticoagulated with heparin. And the standard dosing is the same, that the effluent dose is 20 to 25 ml per kg per hour in acute kidney injury patients requiring CRRT, even on ECMO. So this is what you generally do. Then this is a circuit diagram showing a separate CRRT as well as a separate ECMO circuit. So these are the different modalities different ways in which you can connect an ECMO as well as a CRRT. So now coming to our clinical cases. So you remember this is a 34-year-old male. So no comorbidities. He had a influenza pneumonia, became very sick, and developed an acute respiratory distress syndrome. But his heart was holding well, and he developed for acute kidney injury for some reason, might be the drugs or some sepsis-associated inflammation. He became anuric and became hyperkalemic. Of course, this patient would require a renal replacement therapy, and the modality of ECMO that we are going to do in this patient is a VV ECMO along with a renal replacement therapy. And you can do a sled in this patient because hemodynamically is stable. But of course, one of the most common things that you combine with these patients is CRRT. Now coming to the second patient, this is a 45-year-old female with a strong family history of coronary artery disease who developed acute coronary syndrome, and was taken for an emergency CABG. And post the CABG, she was dependent on the cardiopulmonary bypass, and for some reason the cardiac functions were not picking up. And she developed a cardiogenic shock with a mean arterial pressure of 15 millimeters of mercury. And subsequently, she has developed acute kidney injury with anuria, metabolic acidosis, and hyperkalemia. Of course, she had a dialysis patient, and because it's hypertensive, you require CRRT. So CRRT is definitely indicated, and at the same time, she requires support for this cardiogenic shock. And again, the ideal modality in this patient, if the patient can afford, is a VA ECMO along with CRRT. So thank you for listening to my talk. I once again thank MCure Pharmaceuticals for sponsoring this talk, and Georgia Canines of the ECMG group. Thank you.